Hi all of you. Here we are on the second part of blood flow, second week, and also part 2. So in this section we talk about actually taking blood pressure measurements. And in this diagram first I wanted to make sure you knew the vocabulary. So diastole is a time when the heart is filling, and so you can see the arrows here of blood coming down into the ventricles. This heart is filling, that's diastole. And systole is when the ventricles are ejecting or pumping. So filling and ejecting, or pumping for diastole and for systole. So this is just telling you in words the pressure in the arteries when the heart is relaxed and when it is contracted. Nothing new there. Okay, measuring blood pressure. In order to measure blood pressure, we need to understand two concepts, and one of them is what laminar flow means. So laminar flow is, think of a river that's flowing with no obstruction. There's no big rocks in the middle. It's just flowing without any obstruction, and it's pretty quiet. There's no sound. So an artery can do that too. If it's not constricted in any way, it's going to have a laminar flow, which is pretty silent, as opposed to turbulent flow that's going to produce a sound or a whooshing noise. So Kroktoff sounds are based on these, Kroktoff was the super smart individual who figured this out, that what he could do is listen to the flow in an artery and through that decipher what the blood pressure was. But how do you do that? You'd have to first stop the flow in an artery and then allow some of it through. And so you've got a comparison of that turbulent flow and that laminar flow. So in auscultatory method, what you would do then is have the cuff, as you know, you've all done this or had it done to you. And you will have an inflatable cuff, and you will use an artery which is closest to the aorta. It would be lovely if you could just use the aorta for measurement of blood pressure, but we can't do that. So the closest that we can get to that in the arm is the brachial artery. And what you'd want to do is get a cuff and close off the passage of that blood. So the question is, close it off completely? Yeah, close it off completely. And if you were to listen downstream from that, you're not going to hear anything because there is no flow coming through that artery. However, if little by little you went releasing the cuff, at some point flow would initiate again through that artery, but it would be very noisy because it would be constricted, kind of like the garden hose with your finger on it, right? You're not letting all the water out, so it's going to be noisy. If you remove the finger, it's going to be silent again because the water is flowing unobstructed. So there's the cuff on, and to listen for the sounds, you would have the first audible sound. So remember, we've closed it off here, and now we allow you to open that up, and you're going to hear that first sound at a certain pressure, right? So let's say it's here. At a certain pressure, you're going to first hear this turbulence. That's going to be the top number of yours. So let's just guess here. Let's say that it's 120. And then you're going to keep releasing it to less pressure and less pressure and less pressure until you have no turbulence at all. The flow is occurring freely and you haven't constricted that artery at all for any of the two pressures, and then it's going to be silent. So let's say that that's the one that's 80, 120, and you have your 120 over 80. I always tell the story that we used to do this in our physio in-person lab, and I stopped doing it when I watched a couple students put the cuff on and inflate it. They would inflate it and they'd have it up to 160, and then they'd go stop and go back to their manual and see what step 2 and 3 and 4 were. And And by then, the poor patient, which was another student, was painfully sitting there with their arm in pain. So that's when I decided, no, we're not going to do this anymore. This needs to be done by someone with supervision. You can't just sort of start doing it and practicing. Okay, so with more diagrams here, step 1, you'd have it completely occluded. And then as the pressure starts to go down, it's going to have the first sound. You're going to hear this turbulence going on here, and here it's drawn. They've drawn the turbulence here with little curly lines. And then eventually it's going to be fully open, and that sound dies away, and that would be your diastolic pressure. So this one is your systolic pressure, and here is your diastolic pressure. You get better at it when you do this. At first, you don't think you're hearing everything, and then you sort of gain practice. More diagrams of this. You wouldn't hear a sound if this flow, and it's laminar flow, or if there's no flow at all. But if it's laminar flow, it'd be no sound. The sound comes with a turbulence, and this usually is because this is constricted. All right, let's switch gears a little bit to something called orthostatic hypotension. So ortho means upright, static means not moving. You could have hypotension. So we're going to talk first about hypotension and then hypertension. So hypo, low, would trigger a baroreceptor reflex. So your baroreceptors are your receptors for pressure, correct? And these are monitoring the pressure in the system, which is of your arteries of your body. So let's say that you're sitting down in a chair like my stick man is here, and all of a sudden you stand up. You do it quickly, and what happens for fractions of a second here is that some of the blood that was actually making it up to your heart pretty easily now delays a little bit, and you have a little bit of pooling blood in your legs. And if it's pooling in your legs for a few seconds, then there's going to be a decrease in venous return, right? Because if more of it is in the legs and less of it is making its way up into the right ventricle, then it makes sense that there's somewhat of a decrease in that return. So what would happen next? Well, if there's a decrease in the venous return, then less of it will be in the ventricles, right? You'd have a decrease of blood in the ventricles. All this because you stood up. What would happen next? Well, the blood pressure would go down, because if you have less blood in the ventricles, your cardiac output is lower, you're pumping less blood, so the blood pressure is going to drop a little bit. And that would be a case of hypotension. So this would have to be fixed. So you have this baroreceptor reflex for high blood pressure. You have this mechanism in place. You have to inhibit that and then respond by allowing the heart rate to go up. The heart rate's going to go up and fix then this decrease in venous return and this decrease of blood in the ventricle. So essentially, you are correcting the problem by making the heart rate go up. So baroreceptors are crucial. It's the neural receptors that are checking to see what the blood pressure is like in the system. And where would you put those? So it makes sense that if you are pumping blood and it's going out of the aorta and into the lower body, that you would put some of these receptors right here, because it would allow you to monitor the pressure in all blood that's going to your lower body. But it would not monitor what's going up to the higher top, to the head, to the arms. So you'd need a second set there. And that second set would be in the carotid arteries, because if you have them in the carotid arteries, this is blood that's going up to the head, because head, very important, correct? And, you know, For arms, actually, I included arms, but for arms it would be monitored by the blood in the aorta. You just want to be sure that the head is receiving the correct pressure. So they are then carotid, sinus, and in the aortic arch. That's where those receptors would be, those baroreceptors. So the baroreceptor reflex then is going to result in a more forceful contraction of the heart. If I can contract it more forcefully, I'm going to increase the cardiac output, and I'm going to fix that problem of low pressure. It's going to also cause vasoconstriction, right? If I can constrict those arteries, I'm going to increase the pressure in them. And the pressure, it turns out, is back up in about 2 heartbeats. So here, you're gardening and you get up quickly, you feel a little dizzy. It takes a couple of heartbeats to remedy that and to get that pressure back up again. Well, let's look at the other side of things. What if the pressure is too high? So that would be hypertension. So this isn't a good thing because this constant high pressure on vessels, imagine this pressure crashing against the vessels, against your arteries, could weaken them. And so you don't want that because they potentially could rupture if there's a weak spot on an artery and it's taking this onslaught of fluid that's hitting it over and over again. It could rupture. And you could have cerebral hemorrhage if it's in the brain, so it could bleed out and that would lead to a stroke. Or any kind of weakness in a vessel could burst an aneurysm. So an aneurysm can look something like this, for example, where you have this vessel that actually ballooned out in a little place, and you're having this pounding of this blood in here, and you could potentially rupture something like that, and this could bleed out. And that definitely can be fatal. So these are not good. So monitoring pressure is very important in the body. So there's compensation mechanisms for that high blood pressure under conditions, for example, of high blood volume. So let's say we have blood volume that is increased here. Remember, that's the stimulus. We go back to our aquarium here. And that high blood volume is going to result in high blood pressure. And so that needs to be detected, and it needs detected by some sort of integrating center. And in this case, I'm giving you 2 of them, because one of them is a fast response and one of them is a slow response. And so while the slow response is initiating its response, the fast response can already be working on remedying the problem. So that is compensation by the cardiovascular system. And what's it going to do? I've expanded that now. So what could happen is that you could have vasodilation. And so if you release a paracrine for vasodilation to happen, then that hose that was narrow becomes wider and the pressure in that hose drops. There's less return to the heart, so the cardiac output is going to drop because you have less of that blood returning back into the heart. If the cardiac output drops, then the blood pressure drops. So that's kind of a quick way of shunting blood so that that overall pressure is dropped somehow just through vasodilation. But it's not fixing the problem of your blood volume, the stimulus. The blood volume is too high, and that needs to be fixed. So that's what the slow response is going to be. It's going to take care of the compensation by the kidneys, where it's going to excrete that fluid in the urine, and that blood volume is going to go down. So you've actually then removed the stimulus. We're going to go like this. You're going to remove the stimulus, and then the blood pressure truly goes down, and then vasodilation could just go away, and the system works. So that's a nice illustration that you have in your text to look at. Another concept is that of pulse pressure. And that's a measure of the strength of the pressure wave. You know, I'm talking about it crashing against the walls of vessels, and you want to think, well, is that a problem? And what is that pressure of that pulse? Well, it's defined as the difference between the systolic and the diastolic pressure. So if you had, you know, we could go back to our 120 and back to the 80. That's a difference of about 40 millimeters of mercury. Okay, think of that for a little bit. Hold that thought. The norm is about 40 millimeters of mercury. What happens if that changes? What happens if that pulse pressure gets higher? So what if I had much higher up here, 140, and then below I still maintain my 80, let's say. So now that's 60 instead of 40 millimeters of mercury. So is that useful at all? Well, it turns out that a high value of that pulse pressure, if you increase it beyond the 40, tends to cause more artery damage as compared to high blood pressure with normal pulse pressure. So if both of these are rising, the pulse pressure is going to stay the same. If either one of them drops or the other one gets higher, that pulse pressure changes. So that's one more value that's assessed in, you know, cardiac medicine, in thinking about a pathology. What's happening here? What's the regular mean arterial pressure? What's the pulse pressure? And keeping that in mind, that the pulse pressure is a measurement of potential damage to vessels. I'm going to stop here, and we will continue on the next lecture with atherosclerosis. So this is our place to stop for this mini lecture. Thanks a lot. See you soon. Bye.